Hi all, welcome to Inspired Surgeon Master Course Series. Disclaimer: this video is created for educational purposes. This video is not a substitute for standard textbooks. This video is created in order to train young minds. Some of the images are taken from online resources. Today we are going to learn about squamous cell carcinoma, anus. Look at this image. Do you have any idea what this image depicts? Look at this table. We know dentate line, a very important landmark in the anatomy of anal canal. Above dentate line, the lymphatic drains into internal iliac lymph nodes called line by columnar epithelium. The origin, endoderm, artery, superior rectal artery, venous drainage, superior rectal vein, nerves, inferior hypogastric plexus. Below dentate line, superficial inguinal lymph nodes, stratified squamous non-keratinized epithelium, origin, ectoderm, artery, middle and inferior rectal artery, venous drainage, middle and inferior rectal vein, nerves, inferior rectal nerves. Now you will have idea about this image. The lymphatic drainage above dentate line, they drains into external iliac lymph nodes. Below dentate line, they drains into superficial inguinal lymph nodes. A key landmark to deal about anal canal cancers. What do you mean by anal canal and anal verge? Anal canal is defined by a surgeon or clinician as 4 cm length extending from the anal verge to the top of the anorectal ring. The anus appears as an antero-posterior slit-like cutaneous opening with its distalmost aspect referred to as the anal verge. Now, the tumors that develop from mucosa of any of the three types that can be visualized in their entirety while gentle traction is placed on the buttocks are termed anal cancers, whereas those that arise within the skin at or distal to the squamous mucocutaneous junction can be seen in their entirety with gentle traction placed on the buttocks or within 5 cm of the anus are termed perianal cancers. AJCC TNM 8th edition definition of primary tumor. T staging. The important things to learn about TI is high grade squamous intraepithelial lesion. T1 tumor less than to or equal to 2 cm. T2 T2 less than or equal to 5 cm. T3 more than 5 cm. T4 invading adjacent structures. NX regional lymph nodes cannot be assessed. N0 no regional lymph node mets. N1A mets in inguinal, mesorectal or internal iliac lymph nodes. N1B mets in external iliac lymph nodes. N1C mets in external iliac with any N1A nodes. M0 no distant mets. M1 distant mets. Squamous cell carcinoma. The investigations of squamous cell carcinoma of anal canal or anal region, anal margin cancers. CT, hypoattenuated necrotic mass can be seen. MRI help in assessment of loco-regional disease. In T1 section, there will be low to intermediate signal intensity with respect to the adjacent structures. In T2 section, high signal intensity present. FDG PET initial staging and post-treatment restaging of the disease. PET CT which help in differentiating residual viable anal cancer from post-treatment necrosis and fibrosis. Anal canal squamous cell cancer management. Combined modality therapy with mitomycin C, 5-fluorouracil, radiotherapy 45 to 15 gray, Prophylactic bilateral inguinal irradiation for patients with clinical N0 nodes. Addition of radiation boost for patients with clinically positive nodes. Patients with anal cancers achieved complete remission at 12 weeks may be followed every 3 weeks to 6 months for the first 2 years and then every 6 to 12 months up to 5 years. Loco-regional relapse is more common when compared with distant myths in anal cancers. If recurrence diagnosed pathologically, the surgical management by APR is recommended. Salvage APR is recommended in up to 30% of cases, either owing to primary non-response or subsequent recurrence of the tumor. APR associated with substantial morbidity, delayed wound healing, abscess formation, perineal wound hernia, erectile dysfunction, urinary retention. Any large perineal wound covered with after APR, it is the raw area covered with gracilis flap, pedicle omental flap, gluteus maximus flap, vertical rectus abdominis, myocutaneous flap. Inguinal nodal dissection for a primary failure of chemoradiation and recurrence can be done. For early T1 tumors, wide local excision done. Anal margin cancers. On examination, typically an ulcerated lesion with rolled Everton edges, biopsy reveals well or moderately differentiated keratinizing squamous cell carcinoma in the majority of cases. Investigation, as discussed previously, CT or MRI to rule out distant myths. Prognostic factors. Lymph node involvement is the very important prognostic factor. Tumor size, differentiation, invasion of extradermal structures. Points to learn. Extension of squamous cell carcinoma. With respect to the management, involving the anus, treated like anal canal, combined modality therapy. If it is limited to the anal margin, treat like cutaneous squamous cell carcinoma. Wide local excision is recommended in case of anal margin cancers or perianal cancers. If margins positive, radiotherapy can be given. If large skin defect, reconstruction by rotational skin flap or SSG. Points to remember. Anal cancer should be dealt in two ways, anal canal and anal margin cancers, whether it involves sphincter or not, stage of the lesion, whether it needs reconstruction post-surgery. Thank you. Subscribe at Inspired Surgeon and share to your friends and colleagues.